the human chronic gonadotropin hormone will be the one that we'll be searching for when the patient is pregnant. We have in follicular phase, we talked about follicular phase when we are talking about endometrium changes, but also in the ovary when we have developed follicle before ovulation. In the middle of the cycle, of the menstrual cycle, we're going to have a peak of the pituitary hormones, specific LH and FSH, and also a peak in the estrogen levels. When that occurs, ovulation will be done. And after that, even though we still don't know if the patient's going to be pregnant, we're going to be having the formation of the corpus luteum. So most of the changes that occur in pregnancy are proactive. If pregnancy does not occur, levels of estrogen and progesterone will go down, and that will cause menstruation. The cellular development during pregnancy starts just from the beginning of the fertilization of the egg. And we're going to start seeing by day 2 the formation of the blastocysts, by divisions of the cells. And then during day 4, we're going to start seeing a differentiation of those cells, producing what we call the inner cellular mass. Inner cellular mass, it is important for continuing the differentiation of the cells and forming by day 12 a bilaminar disc formation. That bilaminar disc formation will be responsible to make the distinguished layers called ectoderm, mesoderm, and endoderm. Then, by the enlargement of the amniotic sac by day 23 and the formation of the embryo, we can also see the formation of the umbilical cord, and by day, let me see, by day 7, we are going to see the interaction of the microvilli that's over the syncytial trophoblast will interact with the endometrial. That interaction will permit that the syncytial trophoblast cells produce a signale consisting in HCG, or chorionic gonadotropin hormone, estradiol, and a growth factor that's called epidermal growth factor. That will be a signale for the endometrial to know that implantation is occurring. After fertilization and implantation, which is not susceptible to teratogens, in day 3, in week 3 up to week 8 It's going to be called embryological period. And here we can see the major morphological abnormalities. After week 8, following 9 until delivery in full term, it's going to be called the fetal period. And we can still have some functional defects, but minor morphological abnormalities. So organogenesis is going to occur in the embryological stages before the 2 month. Placenta has a lot of functions. The placenta is there to permit the survival of the baby. So it will have a gas exchange function, nutrition functions. Also, it will provide a removal of waste. And the most important one, it will be there to maintain the activity of the corpus luteum and the continuation of the pregnancy through the release of hormones, human growth hormones, chorionic thyrotropin, chorionic corticotropin release hormone, progesterone, estrogens, glucocorticoids, and the human placental lantogen. This one, human placental lantogen, will stimulate maternal insulin production in order to increase the levels of glucose to the fetus. Also, the placenta will have functions like glycogen synthesis, cholesterol synthesis, protein metabolism, and also the creation of a tolerance through the immune system. It's also a barrier. And even though I'm not going to ask about this, these are the order of the barrier between the mother and the fetus circulation. So there is venous blood coming from the fetus, and there's arterial blood going to the fetus through every villus. So there is a fetal capillary that is connected to those maternal vessels. This is just an information in order to reduce maternal mortality that it's increasing. If you compare the rate in 2019 with 2020, healthcare providers need to understand which are the typical changes that goes with the pregnancies and try to recognize it and differentiate it from the non-typical symptoms or abnormal symptoms. So, in order to understand what is pregnancy, we need to realize that pregnancy has to do with endothelium changes. This is why in later life of parious women, they have greater risk of cardiovascular disease. So markers for oxidative stress, they rise during the first and second trimesters. And free radical superoxide is also generated, including the placental sources. And also, if that radical combines with free iron, it will cause more damages. So, let's try to understand the dual role of the placenta creating adverse and destructive functions, and also beneficial functions. Some of the destructive functions of the placenta is causing damage and apoptosis of cells, but some beneficials for the fetus, for the baby, will be creating invention, immunotolerance, creation of vessels, activation of the vessels, and action as like antimicrobial effects. We need to understand that the oxidative stress is one of the main functions of the placenta, and the way of understanding it will permit us understand why, in some cases, pregnancy is abnormal or we have disorders during pregnancy. So, oxidative stress can be caused by the rise of reactive oxygen species, and this is the list of one of the most important. One is superoxide radicals. The other species are reactive nitrogen species. One of the one that is not so good is peroxynitrite or ONO and nitric oxide. There's some human uterine natural killer cells that have a main function for a lot of the functions of the placenta. So they are called U and K. So natural killer of the uterine cells are going to be responsible for creating new vessels. That's called angiogenesis. They're going to be also responsible for invasion of the trophoblast. Other functions of the extravillous trophoblast cells will be the apoptosis of the vascular smooth muscle cells, as you see here, and also the trophoblast will be expressing major histocompatibility receptors that will interact with the receptors that are present in the uterine natural killer cells, and they will release interleukin 10 to produce an inhibition of cytotoxicity and an increase in immune tolerance. So, during first semester, placenta is low in oxygen because we don't have the connection between the decidual cells and the trophoblast yet, right? That will promote the development of these natural killer cells. Where is this? Let me see where it is. Just a minute. Okay. So, during the first semester, the connection between the trophoblast and the extravillous trophoblast cells, the tip of the spiral arteries should connect to the trophoblast in order to permit the connection of the circulation between the fetus and the placenta, located in the myometra. During the second and third trimester, this This is the normal way it should be looking, right? If any problem or disorder occur, like for example, if you see here trophoblast connection between the spiral artery was not connected by the tip, and the reactive oxygen species are going to be elevated, that will cause a first trimester abortion. Also, preeclampsia and preeclampsia with intrauterine growth retardation can occur when ischemic and wait, give me a minute. Ischemic and reperfusion occurs here. The connection is also abnormal with increments of neutrophils and macrophage. It means of increment of inflammatory cells that will be one of the cause of preeclampsia and intrauterine growth retardation. They are related to inferior EVT invasion with deficient arterial transformation, insufficient uterine artery remodeling, which contribute with highly resistant spiral arteries, hypoxia, and reoxygenation of the placenta. Of course, ischemia and reperfusion will be the inducers of the oxidative stress in the placenta, and that will activate xanthine oxidase and endothelial nitric oxide synthetase, and also NADPH oxidase, and mitochondria in the placenta with patients with preeclampsia. Also, there is, remember the genotypes present in the Kirks. That's this one. Just a minute here. Genotypes present in the Kirk and also on the HLL when it's C. So if the allotypes for that, the allotype for the click haplotype is AA with a trophoblast expressing any HLA-C2, there is a high possibility for miscarriage and preeclampsia. So I went a little bit over some of the things I was saying. Placental hormones, as we told you before, is the human chorionic gonadotropin, and it has effects over estrogen, hepatic synthesis of globulins for thyroxine, corticosteroids, sex steroids. The fetal placenta, it's like a human unit, and it will synthesize also estrogens and progesterone. Estrogens will stimulate a pro-angiogenic factor that's called VEGF, vascular endothelial growth factor. That factors will interact with the placenta to produce some other hormones, and also angiopoietin type 2, which is the one that will be forming the villus capillary bed early in the first trimester. The trophoblasts are going to express a receptor that's called FLT1 that will mediate the response of the VEC-A and the placental growth factor. So we also have in the placenta an oxygen-sensitive transcriptional activator, hypoxia. inducible factor HIF1 that will play a response to any hypoxic condition, and it will be the basic regulation for angiogenesis. So HIF1, VEG, and PEAK and angiopoietins will act together. The corpus luteum, the uterus, and the placentas will also synthesize factor that's called relaxin, that is very, very similar to insulin during pregnancy, and it will peak at the end of the first semester. So during the first semester, the human embryo will require a lot of nutrients, and the most important is to do the connections between the spiral arteries and the extravilus trophoblasts. And those extravilus trophoblasts will attack the vessels and will convert those vessels in like thin walled vessels. During those remodeling will continue during early second semester, and the uterus should be in quiescence state until labor is initiated. All of this, the hormone that's responsible is progesterone. Also, we have nitric oxide, brain natriuretic peptide, prostacyclin, BG, E2, calcitonin. All of those are going to act as relaxators in order to maintain the uterus in a relaxed state and quiescence until labor. We talked a little bit about immunology. We're going to have a systemic inflammatory response during pregnancy. If anything is altered to allow the implantation and placentation and the remodeling of the spiral arteries, that inflammatory response is needed in order to do those steps. And also, we also talked about that the placenta is where hormones and cytokines are produced in order to do a physiologic changes that are needed. So we talked that the EVT or extravilus trophocyte cells will express major histocompatibility complex molecules. The uterine natural killer are different from the ones natural killer that are circulating and have specific functions during implantation and angiogenesis, that the killer Ig-like receptors or KIRKs are very polymorphic, and some of the alleles, like AA, can be linked to pre-eclampsia or miscarriages. And we also talk about the angiogenic factors like the VEC, PEAK, and also angiopoietin 2. So in pathogenesis of pre-eclampsia, we're going to have an increase of ischemic and reperfusion, and that will produce an increase of the oxidative stress stage with endothelial dysfunction and systemic inflammation. Those two processes will be done simultaneously and will produce hypertension and multi-organ dysfunction, basically in three main systems: cardiovascular, renal, and digestive symptoms. in the endothelium, because we talked about that pregnancy is an endothelium disorder, we're going to be having an increase in vasoconstrictor, like thrombosins, uh, an increase in thrombogenesis by the formation of thrombus, and an active production of pro-oxidative enzymes like NADPH oxidase and endothelial nitric synthesize. Also, the production of reactive oxygen species and reactive nitric species, and the combination of superoxide with nitric oxide producing peroxynitrite. That's very damaging. And we can also be seeing angiogenic disorders. So in pre-eclampsia, there is an exaggeration of the increase of the oxidative stress seen in normal pregnancy. And endothelium and also systemic inflammation that will interact to produce hypertension and damage of cardiovascular, renal, and digestive system. That will include and may lead to multiple organ failure and also to death of the patient. We also have change in the cardiovascular system. Usually, and I want you to remember that total peripheral resistance will fall early, also by the peripheral and central blood pressure. Plasma volume and cardio output will raise. Because we have more greater demands on the cardiovascular system, we're going to have more demands on the cardiovascular than in the respiratory system. And everything is done because of the raise of progesterone. The raise of progesterone will lower the total peripheral resistance, and that will lower the blood pressure. That will induce an increment in the sympathetic nervous system. The lower of the blood pressure will increase the heart rate and increase the cardio output. The plasma volume will increase, and that will increase the levels of aldosterone. Levels of aldosterone, when we have also an increase of progesterone, we're going to have an increase of urine sodium excretion that will activate the renin-angiotensin system, and that will increase the aldosterone levels. Aldosterone levels should lower the urine sodium excretion. So we have a lot of hemodynamic changes during pregnancies. Remember, the total peripheral resistance should fall. The renin angiotensin aldosterone system will be activated. The plasma volume will be increased. The extracellular fluid volume will be increased, and the plasma osmolarity falls. The heart rate will rises, and also the cardiac output, with also a raise in the stroke volume. Pulmonary circulation and resistance will fall in early pregnancy, and then it will not have any changes. There is a progressive venodilatation. Maybe because of a local nitric oxide synthesis increase. Pulmonary. Alveolar ventilation and oxygen carrying capacity increases more than oxygen consumption. We're going to have a rise in the tidal volume, and that will be driven by the progesterone also. And also we're going to have a decrease on the threshold and an increase of sensitivity of the medulla oblongata to the carbon dioxide. So progesterone will do a chemoreceptor sensitization with hyperventilation with lower levels of CO2 and lower levels of bicarbonate. We're going to decrease plasma sodium and plasma osmolarity. So if you see the difference between a non-pregnant woman of oxygen consumption will be more, even though P pressure of CO2 is less. We're going to have a hyperventilation that will begin in the luteal phase. A tidal volume rises up to 30%. The falling maternal CO2 allows more efficient placental transfer of carbon dioxide from the fetus, which has a PCO2 of around 55 milligrams. So this hyperventilation is important for this. Also, we're going to have a rightward shift of the maternal oxyhemoglobin dissociation that will facilitate the oxygen unloading to the fetus. In renal filtrations, it also will increase filtering sodium, activates renin-angiotensin system. We already talked about that, allowing sodium retention and increasing plasma volume. So we have an effective renal plasma flow is increased by 6 weeks of gestation, with also a glomerular filtration rate increase, a lower creatinine concentration falls, and a rise in the natriuretic peptide. So the rise in the natriuretic peptide this stimulates the renin-angiotensin system, which increase synthesis and release of aldosterone during the first trimester. Also, what happened, we're going to have a reabsorption of the potassium and glucose excretion may rise, calcium excretion too, and protein albumin excretion also will rise. We're going to be elevation of the synthesis of erythropoietin. Maybe that's stimulated by the human chorionic gonadotropin. And okay, weight in normal of if the woman has a normal BMA, she's going to gain a weight of approximately 12.5 kilograms, and some of this weight is retained after delivery. The fat will be around 2 to 6 kilograms. And remember that pregnancy is associated with insulin resistance and hyperlipidemia. That will be fat accumulation and deposition. That's why it's weight gain. Okay, so we have an hyperlipidemic and also glucosoric during pregnancies. But we have a well insulin response between 6 to 12. So glucose concentration will be falling a little bit. But by the end of the first semester, we're going to have an increase of blood glucose following a carbohydrate load is less. So at mid-pregnancies is when we're going to develop a resistance to the action of insulin, and glucose concentrations can rise. If glucose crosses the placenta and gets to the fetus, that will be beneficial. But if that concentration is more than normal, we are going to expect larger size of the fetus and overweight. So why do we have insulin resistance? Maybe because of the increase of cortisol, but the basic main reason is the incremental of the human placental lactogen. That is the main responsible of insulin resistance in pregnancy. If we have high concentration of adiponectin in early pregnancy, that will enhance maternal accumulation of nutrients. The contrary is also true. Subsequent fall in adiponectin facilitates allocation of nutrients to the fetus. So there is an inverse association between maternal serum adiponectin and fetal growth across the full range of birth weight. Lipids, serum total and low LDL cholesterol will fall, HDL will rise. There will be an increase of free fatty acids during pregnancy and also of VLDL. There is a hyperlipidemia of normal pregnancy that is not atherogenic, does not cause atheromas, but it could mask pathological hyperlipidemia that the patient had before getting pregnant. We are going to accumulate fat in the mid-pregnancy. It's a way of getting energy. The leptin hormone is a sensor alerting the brain to the extent of body fat. So hypothalamus, which contains the appetite regulating centers, is desensitized to the effect of leptin during pregnancy in order that the mother will contemplate getting more food. So those plasma leptin are directly correlated with insulin resistance during pregnancy. We are going to have iron deficiency during pregnancy. Take that into account. We're going to have raise in cell mass, red cell mass circulation during pregnancy, and serum iron concentration will fall. Erythropoietin will rise. Total white cell will rise. Also, T and B lymphocytes counts will not change, but their function will be suppressed. And plaquettes won't change in number. There are different changes about we have like a low grade of coagulopathy. Coagulopathy changes or coagulation changes during pregnancies. It will depend on the time and labor or delivery. It's not the same during pregnancy than after. So some factors that we point here: fibrinogen factor 8, factor 7, and 10 will rise. Fibrinogen doubles. And here is some of the summary. Depending on the metabolic phase, if we're 0 to 20 weeks, we are going to be in an anabolic phase, the maternal anabolic phase. After 20 weeks, we're going to